This is the No Stroke Podcast with your co-hosts David Dansereau and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome to episode 74 of the No Stroke Podcast. I'm Dave Dansereau. I'm here with my co-host Mike Garrow. Hey, Mike.
David, happy belated 4th.
Yeah.
Did you have a nice weekend?
Yeah, we had a hot one, but it ended up with a little after party. Got after the neighborhood town hood race and parade got caught short to a downpour. I don't know if you guys escaped the rain, but it was a soaker here.
No, we avoided the rain for the most part, but yeah, it was a nice couple days off. Yeah. Except, like I was telling you, then I ended the weekend by getting my car sideswiped.
Sorry,
but hey. Thankfully, the guy had insurance, and
all right,
we got that sorted. But
all right, no one's hurt, right?
Nobody's hurt.
So.
Nobody's hurt.
Okay.
So we're back here. I think the timing for this one works well. A recurring guest now for us,
yep.
Dr. Lester Leung at a Tufts Medical Center, and we do have a couple survivor interviews coming up to kind of get us through the summer, and excited for those. But yeah, today I think this is a good one. On just obviously all the work Lester has been doing in this space, so kind of get caught up on some of his work with now a new clinic, Headway Neurology, which I was thinking about the name. I do like it. Yeah,
it really, exactly. If you look at the meaning of Headway, and like he's just pushing into and making progress despite barriers. I guess it's a nautical term. Site and logo look great. We're going to put all that information in the show notes, but we're excited to reintroduce you to Lester and hope that everyone goes back and looks at season 2, episode 7, because we got into on the clinic side and the hospital side with him previously. And on this episode, we're going to dive into his new venture. He's a busy guy, but he's determined that this is, as we mentioned to him after, and you'll hear during the podcast, we left off with a magic wand that he is actually bringing to life with Headway. So it's really, really impressive, his dedication, and we're just so happy that during his soft opening over the summer here, we're able to call some more attention to what he's doing, because it's it's definitely worth the listen.
Yeah, and I saw we didn't cover it too much on the episode, but I saw he put out a post on LinkedIn asking for some recommendations, and maybe we'll have to have this as another question when he comes back on. But obviously he's based out of Boston. That's where his new clinic is going to be located, kind of in the suburbs of Boston, and main reason for that is because it's difficult for people to get into the city and navigate the parking, all that nonsense, right? So a plush, beautiful office location in was it Newbury? Newton, yeah. But he put a LinkedIn post out around just some insights around out-of-state telehealth providers, right? So I think potentially, right, what he's going to be trying to do is offer this as a service, no matter where you're based. Potentially, I'm not sure. And again, that wasn't something we covered, but maybe we could, have it as a topic in our next intro. If we could shoot him a message and kind of
absolutely
get his.
Yeah, but, and I think, and Mike, I'm sorry.
No, go ahead.
No, I just I think that. We joked with him after the pod. I called him the Andrew Huberman of neurology, because when you hear how he dove into talking about the basal ganglia and being that detective and sharing, I think that's what Headway is about, bringing that extra layer in the education. And that's, selfishly, I'm glad he is moving closer, because as I shared in the first episode we had with him, he happens to be I'm lucky to have him as my neurologist as well. So this is a good one. And Mike, it was also nice to see with the innovation and the digital components that he's going to talk about, that 2 of his mentions were past guests that we've had. We just finished an episode with Vivastim, and he mentioned them, and vagal nerve stimulation therapy with Pierre VNS, and also going way back to our first season, we had Brian Harris on with Med Rhythms, and it's a technology that he plans to bring into his practice there at Headway as well.
Yeah, making that connection of kind of what's out there, and having the comfort of, like, as a patient or survivor, caregiver, trying to evaluate the different tools, whether digital or non-digital, right? It's like there's so much out there. So I think, like, for what he's doing to think through and even have some of these devices he was saying, on a shelf that he could kind of pull out and make survivors feel comfortable in terms of what's being recommended and what they'll be using. We need more of it. And I think, obviously, like, the digital health, digital therapeutic industry as a whole, right? That's the biggest challenge, right? Is getting this into patients' hands. Obviously reimbursement as well, but he's up to some great stuff. And then, touched on some of the stuff with the SIA Consortium as well.
Yes.
Excited to kind of get you guys a little inside look of what we've been fortunate to work on with him as well.
Yeah, that's great. Just one quick in the news. You can now find our podcast on babyboomer.org, Mike. Our feed is officially live on that platform and communities. We welcome anyone that's already listening in, because most of our episodes have pulled into their community at this point. So thank you for the folks there who gave us the invite to join their community.
Yeah. Is there a millennial.org or Gen Z? Gen Z's TikTok, I guess.
You'll have to find that. I'm glad there were no comments about me being in the babyboomer.org, because I am not there yet. Not there yet, my friend.
All right. Well, let's get into this one. Again, a happy 4th for all of you that were listening. And all of our listeners, again, if you like this episode, please share it. Like, subscribe. It helps us. And we'll be back soon with another guest.
Enjoy.
Hi, and welcome back to the No Stroke Podcast, Lester.
Thanks for having me back.
Yeah, we're excited to bring you back on and catch up on all the great work that you've been up to over the last few months or years since we've had you on. Yeah. I know David's wearing the shirt, but for the listeners, I know we did a good bit of promotion on our side. Do you want to kind of share what sparked the SIA 5K up at Trillium a couple months back?
Yeah, I think that this is definitely like a culmination of the work of Kate Skills, who's the stroke nurse practitioner and stroke center nurse manager at Tufts, who's kind of my close partner in everything that I do. And she had been for a long time wanting to build a stroke fitness club. She's very much into wellness and tying that to medical care and getting people active again. And she had encountered Jenna from Fit to Function Recovery, and with the collaboration with you guys, it just seemed like a nice kind of coalescing of a lot of different groups of people who are working in the same space. So we had kind of hosted this event at Trillium 5K and had, I think, a nice turnout.
Yeah, it was great. I know David's supporting, wearing the shirt. And I think, Kate, to your point, right? Like, going back to when we had you on that podcast last, I think season 1, episode 7. So I think was that season 1? So it was episode 7, just episode 7, David.
Yeah.
Look at
that.
That.
That's when
November.
Yeah,
November. So it's been a little while, and I know you've certainly been up to a lot, but would really encourage folks, we'll call this out, in the intro as well, but really to go back to that episode and Kate's, right? Because I think our listeners, David and I have had the opportunity to know you guys for a long time now. Obviously, David, you're a treating clinician. David had the opportunity to work with you, but we know your view towards care, that empathetic care that you provide to patients, and really it's a privilege that folks get to work with you, right? So we're looking forward to kind of diving in to some of the new work that you've been up to. But David, do you want to kind of, let's go back. Do you remember the magic wand, David?
Yeah, it was one that really, really resonated. And as we set this up, we encouraged folks in the intro that they should go back and enjoy both of those episodes with Lester and Kate. But I certainly remember Lester, and I'm not going to put you on the spot to recount exactly verbatim on what you said, but it really it stuck with Mike and I because you made the analogy between the lifetime or survivorship needing one-on-one, because there's a lot of pieces to the stroke puzzle, I think you used, and having the expertise to be able to put those pieces together at the right time during the recovery process. And also you said something that the ability to have the medical community and the survivor community kind of working together. And we started off this episode with a perfect example of that, with the intercollaboration and the groups coming together between Fit to Function, Saya Fitness Club, and our podcast, so, and others. So, well, kind of want to feed off of that, because what we want to talk today further expands on perhaps maybe where and we spent most of the time talking about Tufts and your work there, but we really want to focus today on your new venture, and we're excited to talk about your work with your new launch of Headway. And to me, when I looked at your website, it's excellent, by the way. I love the way it's laid out. It's very clear. If I'm interpreting this right, it's almost like where the episode of care ends, I look at like your magic wand almost coming to life with Headway. Is that accurate?
Yeah, no, I think that's a very accurate way of putting it, and it kind of brings a lot of threads together. Do you want me to launch in right now and kind of talk about the idea and what I'm trying to do? So I guess the idea, this is a new program that I'm starting that's called the Advancing Stroke Recovery Program, and it's hosted at a private practice that's called Headway Neurology, which I just started. It's a solo practice. It's actually based out of my own home in Newton. And this is where kind of a separate thread in my life comes into play, which I'll just kind of go off on a very slight tangent, which is that I live in a large kind of old Victorian house, a historic home, and had, with my family, purchased one side, and then our neighbor sold us the other side a few years ago. And we've been doing the landlord thing, having some tenants, and I hate it. It's not a job that I have, and I want to be spending my time doing the things that I love, which is taking care of people and helping people get better, helping them recover better. So I decided to rent out the other side. That's actually where I am right now. So I'm in the kind of future clinic space, which intentionally, partly because of the location, but it's meant to be more homey, a little more inviting, a little bit more kind of casual and welcoming than the typical kind of somewhat more sterile clinic environment that you might find in a hospital. And so to kind of get back to what you're saying, this idea of this program is really, in some ways, it's a successor or sort of a continuation of a lot of the threads that have come out of the Stroke in Young Adults program that I started at Tufts and is expanding in terms of having a lot of influence around the country in terms of people coming together to try and improve the care of young adults with stroke. One of those threads was in my work at my medical center, which also involves some research, but oftentimes innovative practices. One of the things that I found listening to stroke survivors was them coming back to the clinic long after we've quote unquote discharged them, or kind of said, hey, you know what, call me if you need me. And they keep coming back with new problems or new issues. Now maybe they have seizures, or they have cognitive symptoms, or they have severe depression, or neuropathic pain, other things that might be getting in the way of them trying to reclaim the aspects of their life that they want to get back, whether it's their pre-stroke responsibilities like caregiving and work, or abilities, driving, certain fitness activities, and so on. And so that's kind of one piece of it. Like in my practice, my academic practice, we've done a lot of screening of what we call late complications after stroke. And that's been kind of a key part of our work in the Stroke in Young Adults program. One thing that ended up happening as that practice has spread among my fellow clinicians is that going back to Kate and actually another one of our nurse practitioners, Sandy, who work in our clinic, basically they said, Lester, you're dumb. Why are you just doing this for the young stroke survivors? This would help everybody. And so they started generalizing it to everybody, all of our stroke survivors, including our older adults. And we found, studying that that's actually helpful across the age spectrum, and certainly for our pediatric stroke survivors as well. So part of the idea of the Advancing Stroke Recovery Program is that there's no age restriction. It's meant to be for everybody, no matter what time of life one is affected by a stroke. But it's meant to be really a longitudinal relationship, whenever possible, whenever someone might need that. So there's a lot of flexibility built into this care program, with the idea being that some people may need help for decades. Some people may just want to come back every once in a while, sort of for a tune-up or to kind of re-strategize around something. So for some people, maybe they really want to focus over a 6-month period or a year, especially early after stroke, on really maximizing the recovery. And so I've tried to kind of design an idea that's as customizable as possible for what people need. But a big focus is really in the chronic stroke phase, however one might define that. But typically where, as you're describing in terms of the kind of episode of care, where the usual kind of typical standards of care ends, when someone may stop seeing a neurologist or a physiatrist or someone who on the medical side may be helping them figure out the next steps. And so part of what I'm hoping to do is to kind of pick it up from there and help people along with this idea of being a guide or a coach, understanding that I might not be the perfect person for everybody, but I suspect that there is a group of people who would benefit from having a neurologist be that guide. I may not be able to answer all questions, but leveraging the kind of network of people, therapists and other clinicians and other people who support stroke survivors, that I can hopefully kind of get people to the right places, in addition to any medical treatments or other types of treatments that I can offer people.
So can you explain, and I think to my understanding of the healthcare system as it is, I have somewhat of a grip on it, but I know it's very complex, right? So there's probably some listeners sitting here being like, Lester is a stroke nurse or a stroke neurologist at Tufts Medical Center. Like, why can't I just go to Tufts and get this level of care, right? Maybe explain like why this model is needed, like why you had to break off and kind of do this on, as a private practice.
Yeah, and that's a great question. I guess first what I would say is that if someone came to see me at Tufts Medical Center, I could provide them with some of this care. Kind of describes that the experience here would be a little bit different in terms of, what it's like kind of driving in or like kind of walking into the clinic or coming in a wheelchair. And it may feel a little bit different in terms of it just being me here with them, kind of interacting as a very direct experience. There's sort of no in between per se. But I think there are a lot of things happening in healthcare now that aren't new, but I think have been amplified and exacerbated, particularly in the wake of the COVID pandemic. But some of the threads that I think are particularly important. One is that in my field as a stroke neurologist, a vascular neurologist, a lot of my specialty is very hospital-based, very hospital-focused in terms of what happens for people when they're in the hospital. And there's actually a trend for a lot of people in my specialty to be spending more and more of their time in the hospital and less of the time in the clinic, helping people in the kind of aftercare after a stroke has happened. So what that ends up meaning, just from a supply and demand standpoint, is that there's very little supply, even though there's a lot of people who might benefit from that expertise, particularly if the stroke neurologists are attuned to the kind of issues and questions that might be coming up. So I think access and supply is one issue. I think another issue too is just the kind of the idea of flexibility and what type of pressures might be placed on a clinician like myself. Generally speaking, I think one of the things that patients enjoy about their interactions with me is the amount of time that I give to them. And that I think is one of the most valuable things, that we can get deeper into the conversations, deeper into their evaluations, and I can really kind of hear where they are and kind of address things at a much more impactful level. But there are a lot of pressures in terms of shortening appointment durations, a lot of pressures in terms of limiting follow-ups, seeing newer patients, because from a financial perspective for a large healthcare entity, those are the things that actually make money. More patients, new patients, shorter duration visits. And I don't think that I can always provide the level of care that I want to provide in that setting. So I wanted to be able to at least have this additional offering. I'm not leaving my day job at the academic center. I'm still continuing the leadership work, the administrative work, the research, the teaching. But I want to be able to at least carve out a part of my time to be able to help patients in this way.
Yeah, and it's what you just described is happening across all disciplines in rehab, where we're feeling that same pressure, right? The amount of time that we're able to help before they're out the door, and we probably don't see them again. Many PTs are feeling the need to try to do things differently as well, and other disciplines have done that and been able to take back a little bit more control, and like that the time, the thing we're all stopped for is time, right? And so with your able to spend more time with your patients in this format, and thank you for expanding the window, because I'm kind of aging out of the young stroke, and personally speaking, it's going to be a lot easier for me to come see you up in Newton than it is to get into in the city. Can you
Parking's
talk
a lot easier?
Yeah. Can you talk a little bit about, and because I faced this in my private pay practice, your timeline is you're sort of having a soft opening over the summer. So have you actually started to see patients already, or have you had that first patient in the new clinic yet?
So I have my first patient scheduled, and I've had a couple people reach out already to kind of figure out when they can schedule an appointment a little bit later in the summer. But yeah, my first will be next Friday. But like you said, this is kind of a soft opening. I'm kind of working out all the kind of logistical details in terms of kind of records and getting the right information, having the right software to be able to view kind of brain scans and that sort of thing, which is going to be an important data point for a lot of me, helping them understand how I can best help them, and those sorts of things. E-prescribing and getting the notes to the people that want them.
Yeah. The admin behind the scenes, and I think as you start this, right? One of the things, obviously, dealing with insurance. Can you just kind of chat through, as a prospective patient, right, like how that payment model might look?
Yeah, so this is, you asked about like kind of, can someone get this level of care at my academic hospital clinic? And so because I'm starting this as a solo practice, what I'm calling a micro practice, which I didn't invent that term, and I guess it exists out there. Everything is just me. So I'm dealing with all the paperwork. I'm taking the phone calls and all the messages. So if someone reaches out, I'm the one who's responding. And what that means, practically speaking, from a financial perspective, is that I'm not going to be billing for insurance, at least not initially. And so this is a direct pay practice. I have my fee schedule kind of on the website, so that's easy to access and for people to see. I will kind of mention that being a physician, in terms of the consultation charges, they're probably higher than what most people are used to seeing. They're actually probably a lot less than what could be charged by someone in my specialty. I'm trying to kind of find the right balance between making this accessible, but also still paying the rent, which for me is the biggest cost. And so I don't expect this to be a financially profitable venture for me with the amount of time that I'm spending doing this. I mostly am doing this to help people, one. The second thing is to help me make sure that as I'm building my career, that I'm doing something that really is energizing, something that I feel is really making a big impact for people. If my retirement, which is to say that physicians never really retire, but if my retirement were just basically doing this clinic, I think I'd be pretty happy about that. Kind of staying nimble, keep continuing to learn from my patients and the people who are in this community working in this space. But I think it would be a nice thing to continue to do and be able to run even just in this model by myself. But yeah, it's a direct pay practice, taking multiple means of payment. What I am trying to do is obtain as many out-of-network reimbursement forms as possible for insurance carriers in Massachusetts and surrounding states, and partially filling them out just to kind of give people a chance to, at least take my notes and invoices, send them to the insurers, and see if they're willing to reimburse these visits, understanding that the case that I'm trying to make is that this is something that no one else is providing. So hopefully they would understand that.
And with you being able to spend more time with the patient, I know we've talked in the past about the potential for using patients taking the time to see where like the new technologies in rehab fit. And that's an area that's been of interest for me for a while. And I know you've mentioned a few of the technologies that that can help individuals, but it takes some onboarding. It takes some understanding which is the right fit. Is that going to be part of what you're going to be offering there at Headway?
Yeah, it definitely is. And I think that now is a particularly exciting time because I think there's starting to be technology-based treatments that actually have good evidence in clinical trials to kind of show that there's a pretty strong signal for them having some benefits. I do what I'm kind of envisioning and imagining if the various companies that I'm vetting are willing to do that is I want them to provide me with dummy devices that I can just kind of store in all the different cabinets in the clinic and just be able to pull one out and say, like, you know what, this is what this would look like. You hold it so you can kind of get a sense for what it is. There's a very similar model in the kind of stroke diagnostics world where some of the cardiology technology companies that have implantable cardiac monitors, they just freely give out the little implantable monitors, like dummy versions of the devices, to clinicians so that we can have them in the clinic and just pull it out of a pocket and say, you know what, this is what the implantable monitor looks like. You don't have to, there's nothing to be afraid of. It's very small. It's just a day procedure. So I hope to do the same for the various devices that I think actually can help people. With the idea being that this is actually, I think, I had a conversation with Jenna from Fit to Function the other day, and a very nice insight that she shared with me, which is that her impression from working with many stroke survivors is that there are a lot of people trying to sell them something, and a lot of it is technology and other things. And one thing that, and I suppose there's sort of like a wariness on the part of many survivors in terms of trying to figure out like what actually makes sense. And so one thing that I would want to be explicit with my practice is that I'm not getting kickbacks from anybody. I'm not trying to sell people on anything. What people are buying from me is my time and my guidance, my expertise, my care. And so I think I can hopefully help people in terms of figuring out what things might actually make sense for them at a given period of time. So one of the things, for example, that I anticipate helping to kind of assess patients for a lot is vagus nerve stimulator augmented occupational therapy. And for the company that's doing that, microtransponder and the therapy Vivistim, currently they're setting a pretty high bar in terms of what patients they're kind of bringing through the pipeline to receive this treatment, because they're a very young company and they need to show that it works outside of the clinical trial setting, which is very understandable. And so one thing that I'm finding is that as I'm assessing patients for this particular treatment, a lot of people have heard about it. I'm finding that a lot of people are not eligible, but there are things that I can do to help them get into that range. Directing them to certain therapies or starting certain medications that might help their motor system work a bit better. So yeah, that is something that I would consider a part of the practice in terms of what I might be able to offer to people. So.
Yeah, that was a great example of like a handoff, right, for a company or a technology, solution, I guess you could call Vivistim. But there's a percentage of those individuals who just need a little bit more therapy, right? A little bit more movement. And, that's where, the likes of some of these, potential virtual care providers in the PT, OT space could support that as a way to kind of get them moving, get them ready for this treatment. So that's a fascinating way to be thinking through this. When you look at, you mentioned these technology options, right? And I think a big part of that comes down to like how that data informs you as a clinician, right? Because that always, when you look at this world of digital health, digital therapeutics, it's one trying to, get this in the hands of a survivor, right? And to your point, it feels like sometimes they're getting sold something. But if you as a clinician believe in a product, right, you then need to have that device give you data that impacts the way that you potentially could deliver care, right? Would you be looking at that? And when do you have the time, right? Because that's another thing it comes down to, right? Like you are very busy, if you're going to be seeing patients, like how is that patient reported data or the data coming from these devices in your mind? Maybe we're not there right now, but ultimately down the road, maybe when you are retired, there could be a way that everything's caught up where we have some of that data. Do you ultimately see that playing a role?
Yeah, no, I do. This is something that, I think there's one of the challenges of, I think, the physician community as sort of a cohort of professionals is that there's so many generations that are in practice at any given time. Mm-hmm. And even clinicians who may be 5 years older than me, 10 years older than me, are much more technology resistant than I am. I grew up around computers and the internet and social media and all sorts of things. And I have a fitness tracker on on one wrist. But in my day-to-day practice, especially as I'm guiding stroke survivors, I'm already leveraging some of that data. So some of them will come to me and show me like how much they've walked, just showing me what's on their phone. A lot of my patients, when I'm monitoring their blood pressure, they're using blood pressure monitors that sync with their smartphone. And so they can just pull up their phone and show me the trends of their blood pressure over time. I think a big part of it is just, figuring out what pieces of information is going to be useful for that patient in terms of what the care goal is or the kind of recovery goal. And also being able to synthesize it down to a way where it's much more digestible. So just like taking the example of like a blood pressure monitor or like a fitness tracker or like a step counter or something like that. It's not helpful to know like what every single measurement is or like what every day's, amount of steps is. It's more important to see the trends and the averages. So as long as there's some way to kind of pull that together, then I think it's helpful. I think something that I hope to do in this position, kind of interfacing with a lot of the technology companies as a kind of like an unaffiliated clinician, but someone who is seeing patients, is to give them that feedback. So like as they're bringing new things to the market, basically say like, okay, if you want clinicians to be engaging with this thing that you're offering to their patients, you should have some way of reporting out this data in a way that the patient and the clinician can look at it together and be able to understand that. So for example, I kind of gave that as feedback to Brian Harris from MedRhythms, who has this device in Tandem, which is like a little kind of motion sensor on shoes that kind of fits with kind of a smartphone device and uses this technique called rhythmic auditory stimulation, a type of music therapy to help people with improving their symmetry and speed of gait. And one of the things I told him is that device is measuring a lot of data, but you need to kind of find a way of providing that in like a one-page report that's both patient-friendly as well as clinician meaningful and useful.
Yeah, in some ways we need to adopt some of the things that work in fitness, and like if we use it, Mike's just off camera with his Peloton behind us, but they do a phenomenal job of like a monthly report, and it's very motivating. You see where you are. I just started in my practice pulling the metrics from Apple Watches, Fitbits into my platform. And I can tell you in the 3 months I've been doing it with my patients, it is motivating because they kind of know I'm over their shoulder a little bit. And their rehab takes it to the next level. And I just want to add and work off that point because something really, I mentioned this to Mike last week I was in a 2-day workshop with the FDA and the Digital Medicine Society, and it was all about patient-generated health data. That was sort of the buzzword and how it can work for patient engagement. What was and this maybe will lead into what you're doing with the SIA Consortium, because I found that the examples that were given, and they covered multiple conditions, Parkinson's, diabetes, right down to skin conditions, but the focus was on chronic disease. And they gave some pretty powerful examples for when the patient, in one case, I'll just mention, the patient had type 2 diabetes, and they went from being on 11 medications with the use of a CGM and a using the technologies available now, they were able to reduce their care down to one medication, and they talked about how it was transformative. And I walked away and I actually wrote comments to the FDA, because over those 2 days, there wasn't one stroke survivor or caregiver at the table reporting on the potential and how they might be impacted by the potential for bringing technology and digital into the delivery of care. So I'm hoping maybe that's a segue. I don't know if you have any thoughts on that, but I don't know what makes it so difficult with stroke as opposed to Parkinson's or even diabetes. Like, in my opinion, the constant analysis of gait and the potential is almost like having, for the stroke survivors, like having control of blood sugar for someone with diabetes. I just hope that in my career, someday, as you mentioned, this is what you want to be doing. If I could have that magic wand and that crystal to be able to say, what is it going to take to cross the bridge for stroke recovery?
Yeah. So that's a kind of great set of questions and themes. I think thinking about it from a stroke neurologist perspective, I think one of the challenges is that stroke leads to a lot of different symptoms and kind of types of loss of function. And so unlike in Parkinson's, for example, where the whole issue is about movement, whether it's too much movement with tremor or too little movement in terms of difficulty with initiating, for example, steps when walking. With stroke, there are people who have language, like loss of language, or there are people who have weakness on one side, there are people who have loss of vision, or people who are very incoordinated on one side of their body. In other cases, it may be mostly the kind of clarity of speech rather than the language itself being the issue. Deficits could be cognitive in nature. So there's a whole variety of different things, which from like a kind of healthcare perspective, a research perspective, a kind of technology or medical solutions perspective, it really divides the attention to like a lot of different, into addressing a lot of different symptoms, and which on the one hand is it's good that people are working in all these different areas, but it also means that some have really lagged behind. For example, like improving recovery of vision when vision is lost. There's not a lot of therapy out there for that. Whereas in terms of improving language recovery or recovery from weakness on one side, there are many things that are oriented towards that because of the perception that these are very overt and impactful causes of disability. But as you guys know, in your lived experiences and talking to other stroke survivors and caregivers, that all of these deficits could potentially be very disabling and very impactful. So I think that's one part of it. That it's hard to have metrics when you have so many different things you could be measuring. And then I think another part of it is which comes back to the kind of the idea of the coach or the quarterback, whomever is working with someone longitudinally. I think the relationship of the stroke neurologist with a stroke survivor, or really any type of clinician, a physiatrist, a therapist, tends on average to be more short-lived than I think the relationship between, let's say, a movement disorder specialist and a person with Parkinson's, a cognitive neurologist and someone with dementia, a headache specialist and someone who has chronic severe migraines. So that longitudinal relationship, I think, is not a standard thing, and because of that, there's not someone on the clinician side who's demanding that data or demanding that information.
That is true. There are so many layers, and often talked about recovery of one symptom and getting sort of the win there is there's so many other layers under the iceberg, if you will, the tip of the iceberg, as I've heard described. Recovering gait is often in mobility is number one, but then when these things happen throughout the lifespan and you have the late effects that creep up, that's why what I'm so thrilled to know that you're addressing these with and have outlined a plan to be a solution with what you're doing with Headway.
Yeah. I think, looking at some of what you're doing now with Headway, whenever we've spoken to you, Lester, you just give a lot of people optimism, I think, for the future of stroke care, right? And, there's a saying here where it's, right, if you want to go, what is it? Fast, go alone. If you want to go far, go together. And it seems like you're doing a little bit of both, right? If you're going fast, you're creating this, amazing new clinic opportunity and ability for patients to really get this true level of care that they need with Headway. And we're excited for you to continue building that. And we'll certainly, maybe we could do an in-person pod at the new clinic one day. But I want to talk to what you're doing, with the SIA Consortium. And this is important because it's all your principles that you're really building out with Headway, and you're really trying to develop this at a national level. So talk to us about like what was the reasoning for you to want to initiate this group to come together? And I'd love to get your feedback on really driving home the importance of having, the survivor and caregiver viewpoints as part of this working group.
Yeah, no, thank you for asking that. How much time do we have? Because we could go on with this for a long time. But so I guess just to kind of fill your listeners in on the kind of the bigger picture. So the SIA Consortium, which is named similarly to the Stroke in Young Adults program at Tufts, is meant to be a kind of a broader collaborative across the United States of people, which includes clinicians and researchers, stroke survivors, stroke caregivers, advocates, people interested in policy, who can come together to really further the care of young people with stroke across a lot of different dimensions. I think in the narrative, in sort of discussing this with different people who have been very influential in terms of my perspective, a major one being Amy Edmonds, who's the founder of Young Stroke, who herself was a stroke survivor and has done a lot of work on Capitol Hill and with the NIH advocating for young adults with stroke at the policy level and research level. I gather that the US really has lagged behind in terms of finding ways of supporting people who have disability, including neurological disability, finding ways of supporting people who are young with disability and otherwise want to get back to being a part of the kind of broader fabric of society and be doing things rather than being kind of stuck where they are. And so a lot of this is something that has been a part of discussions that I've had with other clinicians and kind of clinical researchers for a while, just getting together at some of the various conferences. And I found that this was kind of the right moment to bring people together because there seemed to be a critical mass of people who are sort of coalescing around the idea of, you know what, we need to be having kind of a shared voice, that there are enough people who want to be putting some energy into this, that we could be figuring out, okay, how can we amplify certain messages in terms of what the healthcare community can be doing? How can we be kind of standardizing or improving practices so that not just a few specialists, but a much broader group of clinicians, whether it's in the acute care hospitalization space or in the rehabilitation and recovery space, or even the kind of pre-hospitalization kind of notification, identification phase, how we can kind of be helping a broader community improve things. And a lot of that, like to the second question that you asked about, like why bring in the patient and caregiver perspective, I think that's pretty obvious that at least, speaking from my own personal experience, this is not an area that I would have had any interest in. It's not something that I trained in. No one taught me any of this stuff, except for the idea that, or the kind of experience that I had just listening to to my patients and hearing what was really affecting them and what was really most important to them, what was really limiting them, and what were they trying to kind of break through. So for me, that's always been very important. And I think a lot of clinicians recognize that that's an important thing, but don't know how to engage with um, uh, stroke survivors, patient advocates, caregivers, just because they haven't had the opportunity to have those discussions in a kind of in a deeper way. So I want to kind of bring your voices and others to the people who are trying to think at the kind of science level or at the kind of like clinical program level, so that they can understand what actually would be helpful for people.
Yeah, we appreciate, having a seat at the table, and I've been moved every time we get together, and it's not easy. The institutions and the groups and the research are all throughout
Yeah.
the country, right?
But now we're at 10, I think 10
yeah.
academic medical centers, and then there's you guys, there's Amy Edmonds from Young Stroke, so it's kind of an increasingly enlarging group, all that are kind of representing all the different regions.
And the goal is, are you going to be meeting up again at ISC in February? I know I wasn't able to make the last one, but to maybe talk about a little bit of the research that sort of the first steps with the group.
Yeah, so this consortium, which again is kind of a combination of clinical research and figuring out best practices to support stroke, young people with stroke and survivors of stroke, and sort of like a kind of think tank in terms of experts and advocates in this area. There are a lot of different kind of projects that we're working on. So, for example, there are a couple of writing projects, one of which is a perspective piece in a major medical journal that we were invited to write, where we're kind of describing essentially like what would be the best practices if we built centers of excellence for the care of young adults with stroke. What would that look like? What are the things that we think are important? Another one of our writing groups is doing a systematic review to try and understand what are the current kind of practices in terms of diagnostic testing to figure out why young people are having stroke. With the idea being that, especially in smaller hospitals and in places where there's less experience in terms of taking care of young people with stroke, the investigations are often incomplete. And so a lot of people leave the hospital or leave the kind of predominant phase of their medical care not knowing why they had a stroke and not knowing if it's going to happen again or what the next steps are to prevent a future one. So there's that group is kind of working on kind of figuring out, can we come up with best practices and algorithm, sort of kind of like a flow chart to help people, the average internal medicine physician or the average neurologist, figure out in general what's the kind of the best route in terms of figuring out what happened. So those are some of the things I think are projects. We've applied for some grants with the NIH, exploring some novel topics like are there kind of aspects or ways in which climate change is affecting the health of young adults with stroke in terms of whether or not they're developing more complications, especially as they're leaving the hospital space, the rehab space, going home. They don't have air conditioning or they're exposed to the kind of temperature extremes. So that's kind of another area that we're looking at. But we hope to kind of build the resources to be able to explore a lot of questions, kind of generate data that can be helpful, whether it's kind of socioeconomic data and it's like cost effectiveness data, whether it's diagnostic data or other things that help to kind of underscore things that are important for young adults with stroke.
With all of your free time, Lester, you managed to do all these projects. For the stroke community, again, we're grateful to have you, and thank you for coming on to the pod again today to kind of share some of these updates. Let's kind of leave it with, if survivors are out here, right, and maybe in the New England area, what's the best way to learn more about Headway, and potentially get a session maybe coordinated with you?
Yeah, I think the easiest way to find me is through the website. So it's www.headwayneurology.com. I have an email address up there, which is info@headwayneurology.com, but they can also email me directly, just my name, lester.leung@Headway Neurology. I, for the first time, started an Instagram account, so have that connected to the website as well as a Facebook business page. But I think, especially if people don't know like what this is about, the easiest way is just to send me an email. I think what I imagine is that a lot of people are going to hear about this through kind of word of mouth, just others who have had experiences working with me, or whether at Tufts or in this space. If it's okay, I actually might just want to tell just a couple quick anecdotes, just to kind of illustrate
Sure.
the ways in which I hope to help people. So we talked a little bit about the technology piece, the kind of like matching people to the things that might be helpful, or the kind of innovative kind of rehab therapies like music therapy and other things, virtual tele-rehab and so on. There's the kind of assessment of barriers piece, which is kind of identifying these late complications after stroke that might be getting in the way and are things that I can treat, whether it's neuropathic pain or spasticity or kind of movement disorders, cognitive impairment, severe headaches, and other things. But there's also this third piece, which I find, again, this is just me as a neurologist paying attention to the experiences of my patients and understanding that there's expertise and knowledge that I can bring to bear. One of which is that, as for example, we're treating patients in the hospital differently and better, and more people are receiving some of the early acute treatments, kind of emergent treatments. We're actually finding that people are often having different patterns of brain injury, and as we kind of help them in the longer term, we find that that actually has an impact on how they recover. And so, for example, there are a lot of patients that I'm taking care of who were able to receive either the medical treatment or the surgical treatment or both for an ischemic stroke, oftentimes with a pretty big blood vessel that's blocked, what we call a large vessel occlusion. And what that ends up doing is that it actually causes a specific area of the brain to be injured, something that's called the basal ganglia. And what we find is that oftentimes people who otherwise would have lost the ability to speak and not move half of their body, and they might end up in a nursing home, now they're walking out the front door. And so for those of us on the medical side, we're kind of like patting our backs and clapping our hands, saying like, yeah, this is a real save. But the strange thing that happens is they come back and see me in the clinic, and everyone's coming back in tears. And you might wonder, why is that the case? Well, it turns out that that structure, which we never really like fully understood before, I think as a field, is actually really important for the control of mood. And so a lot of patients who've never had depression before are coming back with really severe treatment-resistant depression, where their psychiatrists or their primary care doctors are giving them medications and they're not working. And what I found is that repleting some of the signaling molecules that are important in that brain with some simple medications that we use in other parts of neurology actually really helps to alleviate that. And they're able to really kind of restore their mood to something that's much closer to what should be normal for them, which actually allows them to really move forwards. Whereas oftentimes people from a psychological level or mental health level really get stuck. By the same token, that part of the brain ends up actually being really important for movement. And so there's some patients that I have who have been paralyzed and wheelchair bound or bed bound for years. In seeing the experiences with some of these patients who are treated with this medication, I found if I just give them a little bit more of that neurotransmitter, now that person who's been in a wheelchair for the past 6 years is now able to stand up and actually able to activate their leg, able to activate their arm. They're starting to work with physical therapists and occupational therapists again when they haven't been able to do that for years because they weren't able to physically participate. And so I have some patients now who are now taking their first steps after not walking for 8 years or 9 years. And again, part of that is just like using a neurologist's knowledge and just kind of thinking a little bit cleverly, kind of getting outside of my stroke neurologist brain, but thinking about my broader understanding of what happens with the brain and leveraging that experience from other parts of my field to be able to help survivors of stroke, which is not something that most of us in stroke neurology do. We focus a lot on the hospital-based care, preventing stroke, treating stroke when it's happening. But now I'm in this kind of it's almost like a kind of troubleshooting phase, helping people kind of troubleshoot their brain, figure out what's not working, what are you missing, what in terms of something that the brain should be producing or a way in which it should be communicating with itself. So there's a lot of that that type of thing that I'm doing, which sometimes involves medical treatment, sometimes involves other things, directing the types of exercises and things that can be helpful.
That's fascinating, and that's a soundbite that, one of the initiatives that we talk about with the consortium down the road is the education. And I feel like we need to just grab what you just said, because that detective work that you're able to do and be able to break it down, I love the way you just explained that. And I always learn something new whenever we have a conversation like this. So any more? Because I'm like, oh,
Yeah, I mean, I guess I'll give one other example,
all right.
which again, like whenever this is, a lot of this is just the experiences of my patients, right? Coming back and saying, you know what, a funny thing happened, when I did that therapy or started that medication. There's a different medication that we use sometimes that helps with lethargy and fatigue, but it has a lot of different effects, and it functions on kind of a different neurotransmitter, which is NMDA. I have a number of patients who have cerebellar strokes, so strokes in the back of the brain, which, again, a lot of neurologists think that, well, what does the cerebellum do anyways? You can lose a lot of the cerebellum and, based off of our very crude measures of disability, do relatively well or recover well. But a lot of people who actually have cerebellar strokes say, like, I can't balance anymore. I can't do this thing anymore. That really required a lot of fine motor movement or required me to kind of like shift my position very quickly. And so it really affects them if they're quite, high level, high functioning in terms of what they're trying to do. And I found that this medication, which again works for a totally different thing, we've been using it to help with kind of improving wakefulness and sort of energy levels and improving stamina after a brain injury. It actually seems to be helping people with cerebellar dysfunction. So I had one patient who has very severe speech difficulty because of the injury to the cerebellum. She can't really speak clearly or with the right pace. And then she was on the medication for that other reason. And then her speech actually improved. This was about 9 months after her stroke, after she had quote unquote plateaued. And then it just kind of jumped up in terms of the level of function. And by the same token, some people have tremors or they have vertigo or other things that have really kind of dampened down in terms of the severity after starting this medication. And so this is kind of just like a curious thing in terms of like, again, like this kind of, you called it detective work or troubleshooting, however one might want to refer to it, which is to say that a lot of these things aren't, there's not a lot of data for that. It's often just kind of an observation of what seems to be working for people as I'm kind of prescribing something for a different reason, and then talking to others and just say like, you know what, I have these other two patients who were on this medication and they observed this. If you're willing to try, we can try that. I think the risk is going to be low in terms of the risk of adverse effects. Is that something that you want to see if it works? And a lot of people are interested in that because the symptoms are impactful or the deficits are impactful. So they're often willing to try something.
So it sounds to me like you're on track for getting nominated for maybe a Nobel Peace Prize or something.
I doubt it. But
no, it's fascinating.
Yeah. I hope in this small practice, bring it back to this idea. I hope to help what's ultimately going to be a relatively small number of people, but I hope maybe someday this practice will grow. I may have other partners and other people who may join me in it, people who are interested in the same space. I hope that to write about it, to talk to people about it, to see if they are interested and willing to kind of recreate this, maybe on a bigger scale and in other centers around the country, or to kind of build a similar type of idea as a part of their stroke clinics or part of their young stroke centers and so on. Because I think this is just an additional piece. Again, like a lot of people in my field, we're often very focused on the kind of early treatments and diagnostics, but this kind of continued care piece is something that I hope to inspire others to get interested in once they understand that there are things that we can do.
That we can help. I'm not the person to help you with your new Instagram, but maybe some of the clips and some of the great content you just shared will be able to offer that over to you to put it up on your site as well. But we're very I'm very excited to hear more as things progress. And like you mentioned, this is a sort of a soft opening over the summer, so hopefully we get this out to help you gain some traction and awareness. And we just have to stop meeting at 8:30. What time is it now? It's coming up on East Coast
Yeah.
time, about 9:30 plus. I know we all have had long days, and I really, on behalf of Mike and I, really, really appreciate your time and energy you bring every time we have these discussions.
Yeah, bring me back again. I really appreciate it.
Thank you again, Lester.
Happy to talk anytime. So.
Thank you.
Cool.